Hello everyone, thank you for coming. Welcome to this session of NAUTO's 36th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you will be able to enter comments and questions in the audience chat. We hope you will take advantage of this opportunity to engage with our speakers. This session is being recorded. The recording will be available in approximately 1 day by returning to this session in the agenda. We recognize and thank our Petabyte sponsor, the California Healthcare Foundation. All conference sponsors have virtual booths available during the conference in the sponsors section. At the booths, you can learn more about the sponsors, review materials, request contact, and collect game tokens. We hope all attendees will take a few minutes to visit each sponsor's booth. During each conference session, watch for a game token that you can collect for a chance to win a grand prize worth $250 or one of several prizes worth $50. Now I will turn the stage over to Norm Thurston, NAUTO's Executive Director, who will start today's session. Norm, you have.
Thank you, Mara, and it's a pleasure to be with you again today for our second forum. The forum is on preserving secure and sustainable access to healthcare data. I'm especially to recognize IBM Watson Health, who has been sponsoring the forum in this session in particular. And I'm also thankful for Caprice Edwards from NAPHSIS, who has planned this session with us jointly. And so we're pleased to have her. So I'm going to go ahead and welcome Caprice now to the stage. Caprice, how are you today?
I'm wonderful, Norm. Thank you so much for having us.
All right. Well, let's go ahead and get started. I'm going to turn the time over to you.
Thank you so much. So today's panel, we are working on trying to address how do we serve the public's needs for data access while also protecting the public's privacy rights. So today we have a wonderful panel. I am moderating the panel and also partly participating in the panel as well. I come from NAPHSIS, the National Association for Public Health Statistics and Information Systems. We work with the vital records offices throughout the nation. We have 57 jurisdictions. It comprises the 50 states, Washington, D.C., New York City, as well as 5 U.S. territories. Norm, I'm not seeing the slide deck. There it goes. Okay, perfect. So here at NAPHSIS, we have what we call the STEVE system. It is the state and territorial exchange of vital events. Through STEVE, we are able to facilitate the data sharing of all of vital events. I guess I shouldn't say all because it does not include marriage or divorce, but all of the other vital events. Norm, could you move to the next slide? So there's a brief overview. I won't read off our vision and our mission, but you can keep going. That's perfectly fine. So here's a screenshot of the STEVE dashboard just to show how active the jurisdictions are in exchanging data. This is not accurate to today. I took it probably a few weeks back, but jurisdictions are exchanging data on a regular basis. We have 54 out of 57 jurisdictions that participate. One of those jurisdictions, Ohio, we have Devon joining us to talk more about how they exchange data. Next slide. So I'll give a quick overview. One of the ways in which STEVE is able to be utilized so powerfully by our jurisdictions is because of the Inter-Jurisdictional Exchange Agreement. It's a data use agreement that all participating jurisdictions sign, and it really dictates that the sending jurisdiction, when they send out their data is still governed by their jurisdiction's laws. Each jurisdiction has different laws. So they are able to set up different mailboxes, is what we call them, and exchange data with different partners. Next slide. So Devon has joined us. She's the Data Administration Manager for the Bureau of Vital Statistics in the Ohio Department of Health. She's worked extensively with vital records business partners for 17 years through the development of electronic registration system, data sharing policy development, system integrations, continuity of operation planning. And as the Vital Application Administrator, she strives to make Ohio Vital Statistics data accurate, complete, and available. Devon, take it away.
Thank you, Caprice. The states around the nation are connected and we're sharing data. So at the Ohio Department of Health, we register births and deaths. Every day we get data into our systems, and then we share it nationally, and we also share it with other states to make sure that we can mark birth records of people who have died. We mark those as deceased, and we exchange important data that should be matched as far as like infant deaths and all kinds of great things. So part of that responsibility we have in Ohio Department of Health in collecting all this data is also releasing it so that people can do very good things with all this data. So we try our best to make sure our public website has the most popular counts and rates on there. So right now, for example, there's a lot of attention on death data, counting how many people are dying from the COVID pandemic. So we make sure that data is front and center and updated as soon as possible, correctly and accurately. We do a lot of quality control on the back end. And we also have a secure data website where we have more record level data, not just counts and rates, but actual identifying data. And we make sure that we have a good, strong policy in place so that approved requesters, such as birthing hospitals, local health departments, and researchers can get access and do good things with that data. And if either of those options does not meet the need for data, we also have a special file request option. So we try to provide de-identified data. So we might give record level medical information about deaths and causes of death, but we'll redact the names and address of the residents and such to make sure we're also protecting the people on those records. And we really appreciate the use of STEVE, State and Territorial Exchange of Vital Events. It does all kinds of automated exchanging of data to get our records shared with other states. And we can also sign up approved requesters like taxation and voter registration to make sure they're getting that data as soon as they can so that they can do things like cancel deceased voters and make sure that their records are up to date. So there's a lot of options in Ohio that we try to use to make sure data is securely stored and released when appropriate.
Thank you so much, Devon. If anyone has any specific questions for myself or Devon, certainly use the chat, but also you can contact us directly through the systems at NAPHSIS.org email address. So up next, we have Karl joining us. Karl Fernstrom, I hope I pronounced that right, manages the Healthcare Data Service Center in the Health Economics Program at the Minnesota Department of Health. He leads the operational efforts to acquire and maintain healthcare administration data for the MDH, including the MNAPCD, hope you all know that acronym, the Minnesota Hospital Discharge Data, and CMS data streams. He also oversees the creation and release of Minnesota APCD public use files and collaborates with the Health Services Research Unit on emerging research questions and policy issues relevant to healthcare research and health reform within the state. His background is in chronic disease epidemiology with a focus on research using electronic health records and administrative data. Welcome, Karl.
Thank you, Caprice. As Caprice mentioned, my name is Karl Fernstrom, and I manage the Healthcare Data Service Center in the Health Economics Program at the Minnesota Department of Health. And we're the operational side of the Minnesota All-Payer Claims Database, as well as Caprice mentioned, Minnesota Hospital Discharge Data. Today, I'm just going to briefly discuss the historical context and background of the Minnesota All-Payer Claims Database and how Minnesota strives to balance privacy concerns with robust and effective use of our data. Next slide, please. In 2008, the Minnesota legislature asked MDH to establish the Minnesota APCD, and the original use case was to support ongoing health reform initiatives in the state, along with a provider peer grouping project. However, in 2014, policymakers changed their minds and suspended the provider peer grouping project. And at the same time, they reoriented the primary use of the Minnesota APCD to support research on healthcare cost, quality, utilization, and illness burden throughout Minnesota. In the following year, the legislature directed MDH to develop public use files of summary data for the Minnesota All-Payer Claims database. Next slide, please. When the legislature wrote the statute to create public use files, they also established strict privacy guardrails requiring MDH to protect the identity of patients, providers, and payers in the represented in the summary data. When we create PUFs, our goal is to maximize the usefulness of the data while maintaining our privacy guardrails. And there's always going to be a tension between the granularity of the data we are allowed to share publicly and the usefulness of the files to support downstream analysis and reporting. Next slide, please. When we evaluate the re-identification risks in our public use files, we look to HIPAA standards such as safe harbor and removal of direct identifiers, as well as evaluation of indirect identifiers using expert determination methodology. Public data release by Minnesota Department of Health is also influenced by requirements established in our data use agreements with the Centers for Medicare and Medicaid Services. Next slide, please. This table has a high-level snapshot of our currently available public use files for download on our website, along with their descriptions. And we've tried to cover a wide domain of subjects like healthcare services, primary diagnoses, utilization, prescription drug spending, variation in payments to providers, and member-level medical and pharmaceutical expenditures. Next slide, please. Looking forward, the Department of Health is currently conducting strategic planning activities meant to better align the agency with anticipated requirements established in the forthcoming state ABCD grant-making program from HHS, as described in the No Surprises Act of 2020. In addition, the Minnesota legislature has asked MDH to propose a sustainable mechanism to expand access and use of the Minnesota APCD in the form of a legislative report due at the end of 2022. This is meant to piggyback off the No Surprises Act changes that are coming down to the states. As part of the ongoing work, we plan to align our data release and sharing process as much as possible with existing best practices and likely expand the types of Minnesota ABCD file users have access to. Concurrently to our strategic planning initiative, we're also adding several additional years of data to our existing public use files available on our website, along with interactive reporting layer, which Onpoint will be sharing next, some of our preliminary work on this project so far. Our hope is that the dashboards help to further accelerate conversations in the state on effective use of the Minnesota All-Payer Claims database. And for the curious, please visit the sites linked on this last slide for more information about our program. Thank you.
Thank you so much, Karl. Up next, we have Lorie joining us from Washington State. So Lorie Geryk has served for more than 4 years as project manager for the Washington All-Payer Healthcare Claims database, which is currently administered by the Washington State Healthcare Authority. She completed her PhD in public health at the University of South Carolina, where her research focused on psychiatric epidemiology. Prior to joining the, well, I didn't say this acronym earlier, the APCD program, Lorie completed a postdoctoral fellowship at the University of North Carolina Ashlim School of Pharmacy, examining aspects of e-health, chronic disease, self-management, and health communication. Lorie, welcome.
Thank you, Caprice. Good morning, or I suppose good afternoon, depending on your time zone. I happen to be on the West Coast, and as Caprice mentioned, I work for the Washington State Healthcare Authority and am program manager for the Washington All-Payer Claims Database. We call it WAPCD or WAPCD, so I'll use that term as we go forward. I've been with the program for over 4 years, and the WAPCD is a state-mandated APCD. The original administrator was the Office of Financial Management, And they were charged with standing up the database and launching the public-facing website, Washington Healthcare Compare. And in 2020, the program transitioned from OFM to HCA, and I was fortunate enough to move with the program. So very good to be here with you today. This slide really just summarizes the main topic that we are all here to discuss today. I think APCD programs are engaged in a balancing act. So here in Washington, on the one hand, statute says, the database shall support transparent public reporting of healthcare information. So how do you take that mandate and provide useful healthcare claims data to Washingtonians while at the same time safeguarding their privacy needs? And really, I think the solution is in the carefully crafted details. So Washington statute and also our specific program policies and procedures that are in place, that's really what we use to help us carefully evaluate data requests that come in and responsibly release the data. Next slide, please. Thank you. For this slide, I just want to point out that we have two main avenues for releasing data in Washington. So one is that each year we post refreshed cost and quality data on the website that I just mentioned, Washington Healthcare Compare, so that Washingtonians can see provider ratings and prices for services and procedures. So if you are having a knee replacement surgery, you would go there, you would type in knee replacement, you'd type in your zip code, and what you would see returned would be the hospitals and outpatient facilities that provide that service. You would see star ratings for those providers, and you would see the average cost that those entities charge for knee replacement. We also have a cost calculator. You could type in your own insurance details and find a more specific cost that you might expect to pay out of pocket for knee replacement. We also post a public use file that Onpoint produces for us out on Washington Healthcare Compare that contains cost and quality for facilities and hospitals and practices. It's broken out by region and other, county, for example. But this slide really gets at the second main way we release data, and that is through the data release program. Is what we call it, where, as an example, if a University of Washington researcher or any of you email us and say you'd like to do, for example, a longitudinal study, you'd like to look at chronic liver disease, and you'd like to have data that is pre and post-pandemic, in order to do that research, you would go through the process outlined here with us. And assuming the data that you're requesting meets statutory and program requirements, then this process actually ends in what we call execution of a data use agreement, and then delivery of the data product to you. Next slide, please. So Washington statute calls out different categories of data requesters, and those categories then are associated with different levels or really an ability to receive sensitive data. So you can see here that the researcher category there listed first is the least restrictive of the categories and what they can request and can receive. They can request PFI, direct and indirect patient identifiers, unique identifiers, or any combination of those. And I just want to, there's one caveat there. Researchers have to provide their IRB application and an approval or exempt letter, and that's an additional layer of protection that we have. So the second category, government and tribal entities, they can request all of those elements, but not direct patient identifiers. And then we have that third category. It's kind of an other category. That's restricted from requesting PFI and direct patient identifiers. And then this last category, anybody can request what we call a release upon request data file. Those data sets are simply de-identified and they don't contain PFI or PHI. And next slide, please. And really, this is just a snapshot of the data products that we offer. And so you can see the range there. We have an analytic enclave subscription where you go into a cloud-based environment, very secure. You have analytic tools available for you to do analyses. We have a data extract that we can customize for you and send that SFTP transfer. We have a custom analytic report. If you don't have analytic capabilities or time, we could pair you with an analyst who can work with you to answer your research questions and provide a report for you. And I've already mentioned the last two, release upon request data product, and then the public use file is publicly posted. You can go out there right now and actually see that. So again, I'm looking forward to the discussion and thank you very much.
Thank you so much, Lorie. Very fascinating how many different ways. We've already talked about the data is able to be shared and released depending on all the circumstances around the request. Up next, we have Sam Chick joining us. Sam is the Data Analytics Process Manager at Onpoint Health Data. He is part of the process and product development team at Onpoint Health Data, spearheading data and analytic innovation for the organization. He has a strong background in healthcare claims analysis and data science, with specific expertise in the areas of data extraction, manipulation, analysis, and reporting. He is proficient in the development of summary reporting specifications and in the detailed methods for addressing client questions and needs based on technical knowledge and data sources. He's going to do a quick demo for us. So Sam, take it away.
Hey, thanks, Caprice. Very nice of you to say all that stuff about me. So hi everyone. I'm Sam Chick, and I'm going to circle back a little bit to some of the work that Karl Fernstrom from Minnesota was presenting earlier. So we partnered with Minnesota to help with the refresh of their public use files, and the challenge that we tackled with that project was, how can we further that strategic goal that Karl mentioned of providing interactive dashboards that support and complement these public use files? And moreover, how can we report data effectively and engage potential users while using a data set that's already been pre-aggregated for public use? So the solution that we came up with was to create a set of reports that focus on some of the key questions that are addressed by each public use file. And the example that I'm going to highlight today is the utilization puff. I'm going to call them puffs going forward just because it's a little easier, rolls off the tongue. And so this puff dashboard aims to answer the question, in what types of settings do Minnesotans receive healthcare? And this, as you can see, is just one of a unified set of public-facing reports that is currently in development by Onpoint in partnership with the Minnesota APCD. And I want to strongly emphasize that word in development. Everything you see is currently still a work in progress, but hopefully it'll give you an idea of the kind of work that we're shooting for. So the guiding principle, actually, I'm going to click into my utilization dashboard. I'm going to click into my utilization dashboard. So the guiding principle really here was, in our design, was to keep things simple up front for new users, to provide a low barrier to entry, but also give the option to drill into this data, hopefully pique interest, and ultimately drive users towards the Minnesota public use files as an analytic resource. So the dashboard itself, you can see I've arrived at a home page here that allows me to choose between multiple different reporting years, as well as different utilization categories. So right now I've got 2019 as my year, and emergency department as my utilization setting. Below that, you can see a number of key performance indicators that highlight key metrics associated with each type of public use file. And these indicate performance for the selected year, 2019, compared to the previous year, which in this case is 2018. One thing I want to mention here and stress is that it's very important in this type of work to define a set of metrics that is going to be both informative and feasible to report using the pre-aggregated data from the puffs. So quite a bit of thought went into choosing these. You can see we have a number of different rate metrics, total utilization per member per year. So essentially, how often is the average person utilizing this service? So we can say from this, that the average person in the state is receiving about 1.4, or is going to the emergency department 1.4 times every year. And obviously that's going to be a lot less for some folks and a lot more for others. So below that, we have a trending graph that helps to contextualize the current year metric against historical ones, as well as a measure map that provides some visibility into geographic variation among other counties in the state. And the point I really want to illustrate here is that it is very, very important to provide context, especially in public reporting, since your average user isn't going to know what is a good or bad or high or low typical value for a given metric. So to say 1.4, or to say the average person is visiting the ER 1.4 times in a given year doesn't really mean anything out of context. But from this graph, I can see, or from this dashboard, I can see that that value is the highest it's been in the last 7 years, and that it has a wide range across the state, with the highest rate being in, I'm going to butcher this, Monoman County, with a rate of as high as 3.7 visits per member per year. And as I mentioned before, we also want to provide drill down capability for potentially the more analytically inclined users to explore this data more directly. So if I click into my jump to utilization drill down, I'm going to move to a different dashboard, which gives me quite a few more options. And here I have the option to choose between different utilization metrics and different dimensions to group my graph by. So you can see I have a list of different metrics I can choose from. I'll go to total utilization. And you can see I have utilization categories selected as my grouping metric, but I can change this between product type, county name, age group. And each time it's going to rearrange my graph so that I'm viewing my measure broken out by my chosen dimension. Lastly, I can also filter my population using any of the fields that exist in that original utilization public use file. So things like age group, county, payer, service year, sex, utilization category. These are all going to be things that exist in that file, but users are going to have the ability to interact with directly right here in this dashboard. That said, I briefly want to speak about some of the ongoing challenges we're facing. First and foremost of which is accounting for changes to the APCD landscape that impact data generally more than natural trends. I'm speaking here mostly about the infamous Go-Bay decision, which led to a loss of a lot of commercial data, particularly for self-insured members. And you can see this in action here between 2015 and 2016. You can see total utilization drop quite a bit across every category, and that's when that decision went into effect. And we lost a lot of important data. So the challenge there really is to provide adequate documentation to make sure that users understand what they're viewing and the context around it, so that they don't misinterpret results and draw incorrect conclusions. So in summary, I hope I've given you a little better sense of some of the methods and challenges of creating public-facing reports, and I'm looking forward to your questions. Thank you.
Thank you so much, Sam. We did have a quick question. Are those Tableau dashboards?
Yes, they are.
Great. Well, this is a panel discussion, so we'll certainly welcome back the rest of our panelists, and thank you all so much for that overview from your different perspectives. I think one of the common themes across all of the different presentations is how varied the responses are based on who the requester is, the use case behind it, and just making sure that protecting the public's information is always first and foremost. Absolutely wanting to make sure that we're addressing the goals of making the data available, but the privacy of those individuals stands beyond anything. So there's a game token for this session at the bottom of our screen. If any of you are playing along with that, it's de-identified in case you're not looking right this minute. So I went ahead and gave you that. So please do enter that into your dashboard. So any questions from the audience, we'll take in our chat. But one thing that I did want to kind of open up, revisit for everyone here is, how do you see, moving forward? different, use cases across the board, but what are some things that you think are important to keep in mind? I know something that is on everyone's mind these days is COVID. So perhaps any comments that you have regarding how has your agency responded to the COVID requests? Have there been an influx of the requests for COVID data? And any thoughts that you have about moving forward, how to help answer all these questions?
I'll jump in first, just to quickly say, I'll predict that, I used the University of Washington example earlier. I'll predict that we'll be receiving a lot of similar requests for, longitudinal studies looking at pre and post COVID outcomes. Because it's claims data, we're not seeing any requests for public health surveillance use cases. And I think, there will always be a delay or what we call a claims lag between, when a service occurs and when the claim or encounter for that service is in our database. So I think it's really, just thinking carefully about, what we have in the data set, and that lag is a really important component to think of when you're considering COVID research. Others?
I would second that. I mean, we haven't seen a ton of requests for Minnesota APCD data to support COVID analyses in the state because of that lag. We're starting to kind of conceptualize more longer-term studies of the impact of COVID in our state using the APCD. But, the agency in general had to totally reorganize and to address the surveillance issue. And so we had to go out and build relationships with health systems and, the people who have the data more readily available, and build reporting pipelines and reports and weekly reports, daily reports, all that sort of stuff. And, kind of just, I've been involved in the reassignment, and, we built a COVID bureau in the agency. And my observation is it's really kind of exposed, I think, areas for improvement for streamlining reporting and analysis of healthcare data in the agency. And I think it's raised it up as a priority.
Thank you, Karl. Devon, from Vital Records perspective.
Well, the COVID pandemic, it definitely brought to light time-sensitive nature of data. We need to have data as fast as we can to recognize when outbreaks are getting worse, when deaths are starting to increase, and then we started to target in on more details as the environment started to change. At first we saw a huge loss with a lot of senior citizens, and we recognized that we had to break down our data pretty specifically with age groups as well as locations to figure out, who exactly was most at risk, and then making sure we got that data correct before, we released it as timely as we could. So it's definitely a careful balance, and there was a lot of education that had to happen with people downstream. It's like, well, yeah, we do get death data very quickly with great help from funeral directors and coroners, but unfortunately, it takes another few hours at least to get those codes on there to pull out the COVID deaths and make sense of all that data. So it was definitely a once in a lifetime opportunity to be working with health data these past 2 years. Never thought, I would be this involved in my career, and I feel so lucky and so grateful to be able to help in a very small way and support just healthcare, this nation, in this terrible, terrible time. I'm glad we can all help.
Yeah, thank you, Devon. I think that's certainly felt across the nation, across all the different data providers in all respects to the pandemic. We do have a question specific to Onpoint, Sam. So since people are having a difficult time remembering the enormous impact of, I'm going to butcher this, Gobley, do you believe researchers should be compelled to add a disclaimer to any publications describing the impact?
Yeah, I mean, I think as a general rule, it's important to call out. I think unless you're a member of the Supreme Court or you're literally an attendee of this conference, you probably aren't familiar with that decision. So I think in general, it's important to note to anybody who might not recognize the context of the situation. But that said, I think there's other ways. There's situations where the impact is more noticeable than others. Particularly initially in the dashboard I just demoed, some of the metrics we were showing on that homepage were totals instead of rates. And so that the go-beta decision is going to be a lot more obvious when you're showing a total, because your population is going to fall off so significantly between 2015 and 2016 that it's going to be very obvious. Whereas if you're showing rate metrics, your population is, or your metrics are going to hopefully account for that a little better, since you're just not counting a segment of people. There was one more point I wanted to make. I'm sorry, I totally forgot. But yeah, I think just being mindful of the situation, the measures you're reporting, and I think fortunately now we're kind of reaching the point where 2015 is far enough in the past that we it's not being reported in a lot of cases. So that's fortunate, but it's always good to keep that in mind and make sure you're calling it out when it's not obvious to the audience.
Thank you, Sam. There's another question here from the audience. What are your plans to reduce the probability of successful re-identification when adversaries connect multiple data sets and take advantage of longitudinal patterns emerging by combining data?
I can start, I think, on that one and talk about what Minnesota does. And right now, our strategy is we don't really release record level detailed information. We only release the public use files, which are aggregated to a point to make that extremely difficult. We don't release direct identifiers. We don't even collect direct identifiers in most circumstances for the Minnesota All-Paid Claims database. And then we make sure that we've done analysis before we release any public use files, making sure that it is difficult or impossible to re-identify people in the data. I don't think the HIPAA standard is absolute, absolute no re-identification, because I think people understand there's just so much data out there that I don't know if that's a realistic goal, but it's very, very unlikely. So we also have our data use agreement with CMS that says no records can have, fewer than 10 people in them, stuff like that. So we look at that and we redact information that falls below our thresholds for not only patients, but providers and payers in the state. And that kind of really raises the bar on the level of aggregation that has to happen, because there's not as many, obviously, providers and payers in the state of Minnesota as there are people. So they're aggregated at a pretty high level before we release them. For our research studies, we're locked down in a secure research environment, and data doesn't come off our environment with our review. And we hold them to the same standards that are established in the guidelines that are established in our statute. So we have a staff member who does a manual review and has kind of a policy that he reviews to make sure that whatever's been requested to be transferred off of the research environment isn't going to be able to be used in a harmful manner. That's the experience in Minnesota.
Yeah, that's great. And really, I think the interesting thing about this discussion is that continuum where when you look at Karl's program, they're less permissive in the data elements that they're able to release, and we are more permissive. So on that continuum, we are able to release PHI, for example, and other sensitive data elements. And we do allow for linkages with other data sets. And as a program, we prefer to do that linkage in-house. So rather than having those entities do the linkages on their end when possible. And then we also prefer to provide de-identified data sets back to the requester. So and again, each case is individual, and we go through and look at what data elements are being requested, et cetera, and walk through the process of what's needed based on the use case. But that's how we approach it here in Washington.
Sam or Devon, any commentary from your perspectives?
It's going to be really difficult in Ohio. Ohio is under a lot of pressure to release more and more data. We have a state data transparency initiative where a lot of data from different agencies and data sets is being gathered for better connection of data sets that can help Ohioans. So with that, there is always risk. So when state law cannot protect us, like Lorie said, the best thing we can do is a lot of the analysis ourselves, as opposed to giving record level data, trying to control it a little bit better and reduce the detail that we release. But it's difficult. It's definitely a dangerous balance.
Yeah, and from the Onpoint side, I think we're in the kind of unique position of being stewards of the data instead of owners. So, really what we're able to do is provide recommendations based on the the type of project and the acceptable level of risk. So, with any release of data, there's always a trade-off between how analytically valuable and rich do you want this to be, and how much do you want to minimize that risk of re-identification. So I think in each scenario, there's a choice whether that's use the safe harbor restrictions, which take quite a big chunk out of the data set with respect to potential identifiers, versus expert de-identification, which is a more intensive process, but I think ultimately leads to better results in terms of minimizing that risk while also retaining the integrity of your data.
Yeah, just to piggyback on what you said, Sam, as being the data steward too, I think it's really important for the audience to understand really just the protections that are in place there for for protecting personal information and also the business information. Today's discussion isn't about the PFI, the proprietary financial information, but Onpoint is in compliance with HIPAA and HITECH, and they do additional certification for, I don't know, it's the Health Information Trust, the High Trust certification that you have. And then we have all worked with the Washington State Office of Cybersecurity, and we have another state office that is the Chief Information Officer, the Office of the Chief Information Officer, and really that required a state security design review for the analytic enclave, and so there's all of these insurances that have gone into the development of the program and in Onpoint taking in the data and securing that data in the database.
Thank you all so much. Any final thoughts before we move into the next question? All right, so what prohibitions do any of you have on the linkage to other data sets?
In Minnesota, we don't have prohibitions in the statute to link out, although we look at it very closely. So if we do need to link to supplementary data sets, we do it in our secure research environment, and it has to be in support of the research question that the researchers are trying to answer. But I would say it's not something that we do frequently.
We here in Washington do grapple with linkage requests on quite a frequent basis. And I just want to step back and say that really it's in the overall review of the data use agreement. So we take a careful look at each individual. We have a data element request form. So we're looking at each specific data element that's being requested. And we are, by statute only able to release the minimum necessary amount of data for the use case that's put forward. We have, anyone accessing the data has to sign a confidentiality agreement. They go under the data use agreement, and there's tons of rules for how to use and analyze the data and display the data. I think everyone's familiar with the example of self-suppression guidelines, and we have language associated with breach. We've got unauthorized use and disclosures of the data, like for implications there, and language for just privacy and security obligations of the data user. So there's this really comprehensive data, kind of look or review that goes into this. And then again, when the study is over, they're required to destroy the data. So there's a lot of things in place in the review process to ensure that linkages are appropriately done, and that when possible, data is de-identified after that linkage, like I mentioned before, and on it goes.
Ohio has the same types of agreements, but again, good things can happen with linkages. So like right now, all the unemployment fraud that was happening this past year, Ohio has done some good linkages and secure environments between state agencies to look at the unemployment claims and death data and current state of Ohio employee data and other data sets to kind of weed out who were those bad actors doing the unemployment claims. And sometimes good things can be done, but yeah, we need to protect it where we can.
So Lorie said a key phrase there that I wanted to just highlight, and it's minimum use. So I think that's something that internally, as we were prepping for this panel, it was something that had kept coming back up time and time again. So just wanted to see if any of our panelists had more thoughts on that concept of minimum use.
I mean, it's a standard in Minnesota for all data access requests, and we evaluate it through our internal data use agreement with projects that are requesting to get access to more detailed data. And we have kind of policies in place and administrative and technical controls to make sure that people are held to that standard. So if they come in to do a research project, they don't get access to all of the data that we have in the research environment. They only get access to what they need. They work in a secure folder that only they have access to, and they can't get into the other folders for other research projects. So it helps kind of minimize the scope of the data that are available to them while they're doing their project. And then when they finish their project, there's a whole review process that happens on the supplementary information reports that they want to transfer off of their environment. And that looks at, it's not really minimum necessary, but it's kind of looking at the content of the report and making sure it's high quality, and if they are sharing data tables, that they're not violating any of the policies that are in place.
Thank you, Karl. So we had a comment back on our response on that question previously about about the longitudinal continual studies, and just that they agree with many points. It seems that expert determination opens up more options. Hopefully more and more data publishers will choose it. Thanks for the answers and this useful panel. You are tackling hard but highly important problems. So kind of along that line of thought there, I know something that we also had discussed internally before was the thought of a data release advisory committee versus a single data custodian. I just wanted to bring that back up to our panel and see the different perspectives and commentary that they would have around that, pros and cons.
Yeah, I can briefly speak to the Washington model. Here in Washington, we have both a data release advisory committee and a data policy advisory committee. And those are the bodies that we really leaned on hugely when developing policies and procedures that we're talking about today. And in addition, the policy committee helped us set pricing for our data products. But by statute, we are required to include different committee members from different stakeholder groups. So we have a wide array of individuals with various backgrounds and expertise to help us with security and privacy issues and implementing the best policies. And I will say too, it's been really important for our program to look at what other APCDs are doing, the rules that they have, the legislation that's in place, because I think we should be continually looking at our program with a lens of improvement and really trying to see what is being done and what the latest is for security measures and releasing data, and really be thinking internally about how we can incorporate those going forward. But we rely heavily on advisory committees. The data release committee actually is the body that reviews all incoming data requests, and they meet every other month.
And just to contrast that, in Minnesota, we're still running an older model. It's pretty siloed. We have a data custodian, we have a business steward, we have a technical steward. And so those are usually one individual within the organization for each kind of data resource in the agency. And they're responsible for making sure that all the policies are being followed and that the use of the data is appropriate and as allowed by statute. And in reality, it's more of a team effort. It's not just one person, it's just one person who actually has the final say. And it hasn't been formalized into kind of a committee structure, but the agency is looking at kind of data request processes and building that out. And I know it's going to be a significant part of our report to the legislature, which is due at the end of 2020, expanding access to the Minnesota Operator Claims Database and getting use outside of the agency. And we're looking at best practices similar to what Washington just described very closely.
Thank you both so much for that commentary on it. I think it's certainly interesting to have these panels that have formed out of, kind of the organic nature of these things to the points that Karl's making. There's multiple hands that have to go into making this decision. So even if it's not a formalized process or panel or a committee, it often does not still fall on one single person. But it's just interesting how different states are handling it differently, and certainly we only have a small selection with the three here. 3 different states, 3 different statutes. There's 57 plus or more, depending on how localized you want to get to that. Well, we'll certainly take any additional questions from the audience. Please don't be shy. Please ask us. We're here to answer questions you might have.
You're very right, Caprice. 57 different ways is often how it feels like we do things around the nation. Absolutely. And again, Ohio goes back to the almost opposite of what Karl and Lorie were talking about, being very restrictive and methodical, where Ohio is often pushed to release as much detail as, we possibly can. We often have to have our legal team step in sometimes when we need to protect data, because we have so much pressure from reporters and researchers trying to get as detailed level of data as we can. We used to have a newspaper that was publishing cause of death and names and everything for, their neighborhood. And, there was just no need for that, but it's public according to Ohio law. So we had to be very creative with our legal team in order to protect that data and those decedents from identity theft and fraud. These unfortunate things were coming out of that. Even though we want to share data and do good things, we need to protect it and secure it as well. So we would rather help the public with important data needs, such as COVID death data, all that spread, making sure everyone's staying safe in their communities, getting their vaccines.
Yeah, Devon, and you're kind of hinting around. So this is a question that Norm asked. I'm going to go ahead and read it out. So what do you perceive your role in meeting the public's needs? You kind of gave some answers already to that question, so I don't know if you had gotten a chance to see it.
So we try and look at what the public needs. Like some of the most popular data requests we've had are for birth counts by school district. A lot of people want to know how their communities are growing. So we try and get ahead of those and get those counts out so that districts can prepare their facilities for all the infrastructure they need as different communities start to grow. And again, like going back to the death data and making sure all the local health departments have what they need as far as, vaccine preparedness and serving their communities or populations, which nursing homes are in their communities. And our local health departments have definitely done a fantastic job in serving all their different communities, because we have the big cities and the rural areas are very different.
Any other panelists have comments on that specific question or point?
Well, we want to, sorry, I'll go first. I'll be brief, but we want to, I see my role as trying to get the data out there as useful as possible and as much as possible while staying within the guardrails in our statute. And, currently the best mechanism for doing that is our public use files. So we've been expanding the scope of the public use files and the amount of data that's available in them, and we're adding this reporting layer, and hopefully that's going to make it more accessible to people who are experts in the field and want to learn more about the use of healthcare claims database. And my hope is it's going to generate, some active policy conversations in the state, and maybe that'll lead to more opening up of the data.
Yeah, that's great. And public needs, just thinking about it, I mentioned before, we put the cost and quality and transparency out there on our website. And I think for the Washingtonian, that's really valuable data. And I just think in general, the key is listening to stakeholder feedback and to seeking that out. For example, we have a really active data user group in Washington that meets on a regular basis. And we have surveyed them, and they are currently asking for death and birth records to be added to our database. So taking those requests seriously and considering them, and just I think really working with stakeholders goes a long way.
Thank you all for that. So one final question: any recommendations or suggestions for managing Social Security numbers? Hashing or other technical tips, asking for a friend? Sure you are. I think I'll toss this to Karl first, because I know his answer is pretty quick and efficient here.
Yeah, we don't collect it. So no tips there. I mean, we do collect individual identifiers, but they are direct identifiers in the data. All of that is hashed using SHA 512 or whatever, the hashing, one-way hashing algorithm by the National Institutes of Standard Technology. And Onpoint runs all of that for us to make sure that nobody is sending us any direct identifiers in that data. And that's hashed at the point of submission. So the health plans, the Medicaid agency, the TPAs, they're all hashing it before they even send the files. And then Onpoint does a consolidation and creates a unique ID using hashed identifiers. It's a variable that's been on my wish list for many years, because not collecting it causes a lot of problems in member clustering and things of that nature. So I would study the mechanisms closely before you make a decision.
Yeah, to chime in here, I think hashing's a really good method if you're planning to join that data back out to other hash data, if you're using the same hash key. Though, one issue we've encountered in the past is as soon as you hash something, you lose the ability to check the validity of it. So if you've got these social security numbers that are coming in as invalid values, all 1s, all 9s, 1, 2, 3, 4, 5, 6, 7, 8, 9. As soon as you hash that, you can't tell that it's a bad social security number, but before you do, you can tell just by looking at it. So, if you are planning to hash and make that available, you want to make sure that you're doing your due diligence first and not after.
Thank you, Sam. And we are at the top of our session, so so sorry, Devon and Lorie, if you had thoughts or comments on it, we're going to have to just hold those. But absolutely feel free to reach out to us. And again, the game token for the session is de-identified. And thank you all so much for joining us on this panel this afternoon. And have a great rest of the conference. Thank you.
Thank you.
Thanks, Caprice.
Bye-bye, everyone.
Bye.